Thank you for taking the time to join us today. I want to thank our speaker, Miss Dawn, who is MSCCC SLP, founder of Miss Dawn's SLP, and Easy Peasy's pediatric speech pathologist and feeding specialist. Hello and welcome, Miss Dawn.
Thank you so much for having me. Thank you, everyone, for being here and bearing with us.
Yes. During today's talk, we're going to explore how oral development impacts feeding habits, discuss key milestones, healthy eating tips, strategies for addressing common feeding challenges. Whether you're a parent, caregiver, or educator, this session will be a valuable insight to your child's feeding journey. Webinar participants, if you have any questions throughout this session, please use the Q&A function at the bottom of your screen, and we'll do our best to address your questions during our live Q&A at the end. So, Ms. Dawn, over to you, ma'am.
Okay, great. Thank you so much. I'm going to share my screen and see if you guys can see this okay.
Looks great.
Oh, if you can see it, yeah? Okay.
Yep.
Okay, great. So we are going to be talking about developmental milestones. A lot of families that I work with and other educators know a lot about gross motor milestones, such as like crawling and walking, but really not understanding a lot about our oral milestones. So like Christy was saying, I'm Dawn. I am a pediatric speech pathologist. I'm an infant feeding and swallowing specialist. I'm also the product designer for Easy Peasy, which is a brand that makes developmentally appropriate oral care and feeding products. I've been in private practice for 23 years, and I've been an SLP and feeding therapist for over 30 years. And in my private practice, I teach these types of webinars for parents and medical professionals to help them be able to kind of work on wherever their child is at as far as the oral motor stages of infants to toddlers to preschoolers. I have been blessed to be in a lot of press. The products that I design and the advice that I share has been featured on lots of different types of media. The products I design are in Nordstrom's, Crate and Kids, and at daycare centers like Kidco. I have fed over 10,000 babies in my career, and I am very excited to share some of those tips with you and help you feed yours. So let's get started with the 3 month old age range. And we're just going to kind of go up from 3 months to 3 years of age. And what's really important about this 3 month time frame is that babies are actually getting really engaged with the objects in their world. And they get engaged with that by bringing those objects to their mouth. So some of the milestones that we're looking for is that a baby is grasping an object. And when we think about their grasp at this age, is that if an object is in front of them, they're using what's called the palmar grasp. And so that's basically grabbing with their palm and grabbing that object like this. And then of course the next step is bringing their hands to their mouth, like if they're sucking on their fingers or maybe they're biting on the sides of their wrist. That is another milestone. And then being able to kind of combine that. So they're going to use that palmar grasp, they're going to grab that object, and they're actually going to bring that object to their mouth. So in this exploring phase, we want to be able to facilitate different opportunities for babies to be able to elicit those skills. You can do that in the high chair. At 3 months of age, your baby's going to be a little floppy in the high chair, of course, but we can kind of position a couple of pillows and different things to have babies sit up a little bit better and kind of work on those core muscles to be able to help facilitate baby sitting up in the high chair. And then having opportunities where we're going to put different objects in front of baby so baby can actually work on that grasping of that object and being able to eventually bring that object to their mouth. This is a feeding milestone because we know and research shows that if we focus on oral care, letting babies be able to bring different objects to their mouth and let them practice that mouthing, you can help baby become more familiar with different textures. And that's very important because we want babies to get familiar with different textures and sensations in the mouth so that they're able to eat different textures and be able to have a variety of different foods. So it helps ensure that they're ready to handle those textures effectively once they begin eating. So that is very important. And when we're talking about offering different textures in the mouth, it doesn't mean that at 3 months old we're offering food. We're not. We're just offering different ways for babies to be able to explore different objects in their mouth. So, and one of the objects that I like to bring to baby is, if you can see this, this is a toothbrush. This is a baby-led toothbrush. And this is an object that babies can actually bring to their mouth. We tend to do oral care for children much longer than children really need us to do it. Kids can do so much more than we give them credit for. And if a developmental milestone is to bring an object to the mouth, then why can't a baby bring a baby-led toothbrush to their own mouth and be able to brush their teeth? I've been teaching across the United States and as well in Europe, dentists, pediatric dentists, about a new type of oral care called baby-led oral care. And that's babies being able to do their own oral care at 3 months of age. So we know that there's this milestone of babies being able to use that object and being able to bring it to their own mouth. Why can't that be a toothbrush? So I designed that to be able to help facilitate babies to do that. And if you go on our website or follow me on social, you can see all these 3-month-old babies just brushing their gums. Now, they're not brushing their teeth because a lot of 3-month-olds don't have teeth yet, but the teething process does generally start around 4 months of age, so a month later. And really what we're wanting to do is to really facilitate some friction onto the gum line in order to break down that sugar. So breast milk and formula breaks down into sugar onto the gum line, and we need to be able to have babies clean that off. So if the baby's just kind of chewing on it, it's okay because those bristles are kind of just breaking up that sugar onto the gum line. And if babies are holding it, and that's the difference between baby-led oral care as compared to adult-led oral care. If I'm an adult and I'm brushing baby's mouth, right, that is the adult doing that process, when we know developmentally babies can do that process. So what we can do is that babies can hold onto that toothbrush, and me as the adult, I can use my index finger and help that elbow to be able to help assist baby with that brushing motion, which can be really helpful for them. And you'd be so surprised to see so many babies actually starting to brush their own teeth. And they can use a baby-led toothbrush from 3 months of age all the way to when they get their first molar. Once babies get their first molar, which is typically around 12 to 15 months, we want to move from a silicone toothbrush to a more bristled brush. So this is a great way to be able to work on these feeding and swallowing milestones at that 3-month mark, grasping an object, bringing their hands to mouth, and then eventually bringing that object to their mouth and still facilitate really good oral care as well. Another thing that we want babies to be able to do is have a variety of different teethers. So we want to offer different shapes and textures to be able to let babies figure out what they want to do to have really good sensation in their mouth. Sometimes one day they might pick out this teether, and the next time they pick out this one. But offering a variety of teethers is really important for their oral development and for the oral care. Again, we want that friction. We want babies to be able to kind of break down that sugar onto their gum line, and we also want to prepare the gum line. This is an example of a mouth, but it has teeth. I wish I had one with just the gums. But what's happening is that when we are allowing babies to facilitate work onto the gum line, then we're actually breaking down that tissue to allow the tooth to erupt a little bit easier. So letting your baby really manipulate with different types of textures at that 3-month mark will not only help the teething process, it'll end up helping their feeding and swallowing process as well. And as we are engaging in this 3-month mark, I really want to encourage parents to use a tongue depressor and be able to start looking in their baby's oral cavity. And I would actually encourage that at birth. So this is a regular tongue depressor. This is a sensory tongue depressor that I designed. You can even use your own fingers. Sometimes tongue depressors make that a little bit easier for parents to do. But as soon as your baby is born, we want to look into the oral cavity. We want to look for a tongue tie or a lip tie or a buccal tie. And that is the skin that's attached to the lip and to the tongue, and look to see if there's any tightness. And I like to encourage parents to be able to do that and to look for that, because unfortunately a lot of medical professionals are not educated on this. And so parents can actually, I like to encourage them to be able to look into the mouth at birth and then look into the mouth every single month to see how that oral care, that oral cavity is changing. And can be really fun. You can just you can show the tongue depressor to baby. Baby might want to hold onto it with you, and then you just kind of look into the cheeks, see if a tooth is emerging, see if baby has any illness. Do they have, pockets of like, sores in their mouth? Does it look like they're getting sick? And we just can start to understand a baby's oral cavity. And then when you start solids, babies are really used to having you look into their mouth, and then it's easy to assess if there's any pocketed food. A lot of choking, and I see a lot of babies who have choked and then are afraid to eat anymore, is as babies are getting picked up out of the high chair, we usually lay them down after they eat. And if we haven't checked to see if there's any leftover food into their mouth, that food, when they lay down, can move back and occlude the airway. So we really want to use a tongue depressor after each meal to be able to kind of look into their mouth. And again, you don't need a tongue depressor, you can use your own finger, but we want to be able to really assess that. So using that tongue depressor early on can really help facilitate feeding and swallowing, because you're getting to know your baby's oral cavity and how it's developing, and babies are getting used to you kind of checking into their mouth. This is going to help with your pediatrician visits, it's going to help with your dental visits, and it's going to make things just a little bit easier for both you and your baby. So moving on to 4 months of age, what's exciting about this age and the milestones for this age group is that we are allowing babies to learn how to be able to munch. So before, they're grasping that object, that they're bringing that object to their mouth, now they're really starting to munch. And what we're looking for is this munch pattern that's this up and down munching pattern. The way you and I chew is we do what's called a rotary pattern, and that is just the jaws are moving and we're kind of chewing like in this rotary movement like this. But babies, they are chewing with a munch pattern. So they're really engaging that jaw, being able to kind of go up and down. And so in order to facilitate that munch pattern, we want to offer babies things that go on to the gum line, not things that cover their mouth, like those silicone food pouches or those mesh food pouches, because they cover the tongue. We don't want anything to cover a baby's tongue. We want that to be onto the gum line. So we want to be able to encourage things that go into the gum line, like certain teethers that can fit really easily onto that gum line. Toothbrushes, like what I just showed you, can easily go onto that gum line. And we also want to offer things like breast milk or formula popsicles that actually go onto that gum line, that allows babies to be able to chew. So I'll show you this one. This is a breast milk and formula popsicle. Let's see if that camera zooms in. Of course it's not. But it's a little
It looks great.
Can you? Okay.
Yep, I can see it.
Okay, so it's a popsicle that can fit onto the gum line that can actually help with the teething process, because we can get breast milk and formula into those areas that the tooth is starting to emerge, but also we're facilitating that nice munching pattern, which is so important for more textures and more feeding as we're moving along. At this 4-month mark, what we can do with popsicle molds is that we can fill up the popsicle molds for babies with breast milk or formula, because baby's primary nutrition is breast milk or formula all the way to 12 months. And then once a baby hits the 6-month mark, and we could start to introduce other foods like purees or mashed avocados, mashed fruit, and put that into the popsicle to allow baby to not only get the nourishment from breast milk milk or formula, but other foods and other tastes and other colors as well, which really can help decrease the length of picky eating. And then also at the 4-month mark, we are going through that teething process. So the teeth are starting to emerge, they're starting to get a little bit more sensitive into the mouth, and we're facilitating a lot more saliva. I have to say that drooling is not normal. And when I tell that to families and when I tell that to caregivers, they're like, wait, no, drooling's normal with teething. And actually it's not. What the case is with excessive saliva is that excessive saliva is supposed to lubricate the gum line as that tooth is starting to emerge. And the saliva has enzymes to be able to help decrease the inflammation as well. But babies are supposed to be able to swallow that saliva. And if babies aren't swallowing that saliva, then that means that their tongue is not going up to the roof of their mouth. So if everyone could just swallow your saliva, notice where your tongue is, it goes up to the roof of your mouth. It's called tongue elevation. And if babies are drooling, then that means that tongue is not elevating. So that lets me know either that that baby is on a pacifier for long periods of time during the day, or that baby is unfortunately on a sippy cup, which we're going to talk more about sippy cups later, but they're not learning that tongue elevation. The other thing is that they're not learning the tongue elevation, and then they're not having palatal suction. So swallow your saliva again and feel your tongue go up to the roof of your mouth, and it suctions up there. So it not only does it lift up to the roof of the mouth, but it kind of suctions up in there. And we really want that to happen. And what that does is with that palatal suction, it pulls all the saliva that's in the mouth and has the child swallow it. So this is very important to be able to help make sure that the baby does not have a high arch palate. And it also helps to facilitate a really good swallow process. Babies who choke the most frequently are babies who do not have good tongue elevation or good palatal suction. So we can help our babies be able to have both of those things if we're practicing on them gripping objects and putting those objects onto the gum line and making sure we're not offering them objects that cover their entire tongue. So that helps with being able to work on that munching, and it helps with the teething process as well. So when you're looking for a teether too, you want to find a teether that has an opening in the middle, because when the baby is chewing on this, that tongue can come up through the hole to be able to help facilitate that swallow that we want babies to be able to have. So you want to be able to kind of look for that shape too, to be able to help facilitate baby going through this milestone and through the teething process. And then around 6 months of age, what happens here is that we get to offer a variety of different exciting experiences. We're going to start with being able to engage baby in solids and starting solids. The premise here, though, too, is that we want babies to wait to start solids till 6 months of age. The American Academy of Pediatrics, the World Health Organization, infant feeding and swallowing specialists like myself, we all encourage parents to wait till 6 months of age. Starting solids any sooner is against medical advice regarding medical boards. So we still unfortunately have a lot of pediatricians that do recommend starting solids at 4 months of age, and unfortunately that recommendations of babies waiting till 6 months of age is 15 years going strong. So that means that those medical professionals who are encouraging parents to start solids earlier than 6 months of age haven't taken any continuing ed in feeding in decades. So it's really important for parents to kind of advocate for that and really know that information, and having caregivers know that information as well, so we can encourage parents to do solids safely. A lot of the babies that I work with that have had choking experiences are babies that started solids too early. So when we're looking for readiness for starting solids, these movements, the hand movements, hand-eye coordination, being able to grasp objects, all of those are signs of readiness for starting solids. So it's really imperative to wait till that 6 month mark. I also want to say, if your baby was premature, even if it was by 2 weeks, you're going to start solids at 6 months and 2 weeks. If your baby was 4 weeks early, you're going to wait to start solids till baby is 6 months and 4 weeks. And that is very important to be able to maintain airway safety for your child. A little bit of coffee to wet my whistle. So at 6 months, some of the milestones is that we can start cup drinking, which is so exciting. Cup drinking, if you take away one thing out of this whole presentation, please let it be open cup drinking. Open cup drinking helps promote feeding issues, swallowing. It prevents, feeding issues and swallowing issues. It helps with speech production as well. The tiny cup, this is a 2-ounce cup, is a great way to be able to help facilitate that. So when I tell parents that the developmental milestone is that babies can drink from an open cup at 6 months of age, they're like, it's going to spill, it's going to go everywhere, I'm going to waste my breast milk, I'm going to waste expensive formula, and that's not the case. We hold the cup. So the developmental milestone is babies will drink from an open cup at 6 months of age held by a caregiver. So I'm going to hold this cup. It's going to be filled with breast milk or formula because that's baby's primary nutrition. I'm going to hold the cup here and I'm going to wait for baby to lean forward to drink from that cup. If I offer the cup and let's see if I can move this so you can see this a little bit angled. If I offer the cup to baby and bring that to baby, baby's head tilts back. See that? Anytime babies' heads are back, it opens up their airway. So if the child is drinking from a sippy cup and they have to tilt their head back, it opens up their airway. The number one reason, the number one cause of ear infections in the United States is babies using a sippy cup, because when the head is tilted back, that liquid can go down into the eustachian tubes, causing ear infections and hearing loss. We want babies' heads down. So we want them like we are. When we're drinking and I'm drinking from my cup of coffee, my head's down, I'm not tilted back. So we want to, with the open cup, we're going to offer that. We want babies to lean forward so they can take that sip, and so they're not leaning back, which is really important. Sorry, baby's having a very bad hair day. So we're going to offer sips from an open cup. What's great about a silicone cup is that it's flexible, so you can put purees in here as well to make that liquid go down a little bit slower too. So it's a great way to be able to offer that. And why we're doing an open cup is we're working on what's called lip closure. As I'm putting my lips onto the open cup, I'm closing my lips. And why that's so important, lip closure is not only important for feeding, but it's also the precursor to speech. So what is baby's first sounds? Pa, and ba, right? So mama, papa, baba for the bottle. That's what's called lip closure sounds. And so the more that baby practices on an open cup, the more their speech is going to come. And that's why you'll hear baby go, when they're like drinking or eating, is because we're facilitating that lip closure. Another milestone is that babies can bring a preloaded spoon to their mouth. And that's actually working on lip closure too. So let's get a bowl. Let's replace this. We're going to get a bowl here. And a preloaded spoon is, this is an adult-led spoon. And again, if we're spoon feeding babies, we're doing that, again, babies tilting back. It's thought of that baby-led weaning, which is offering strip sizes pieces of food, cause choking, but actually the babies who choke the most are babies who are spoon fed. And why that's true is because we're putting babies at risk by having their head tilt back, and then we're putting babies at risk because they're not learning their skills. Remember the developmental milestones, they're going to grab objects, they're going to bring those objects to the mouth. That's why we want to offer a baby-led spoon. This is an adult-led spoon, this is a baby-led spoon. With the baby-led spoon, we as the caregivers, our job is to scoop up that spoon with food and make sure that it's called preloaded. So we're loading that spoon up and we're just going to put it there at the edge of the bowl. Baby's job is to grab that and bring it to their own mouth. We're not doing anything. And that's the positivity of baby-led weaning, letting baby lead the way, is that babies are actually doing their milestones. So they're bringing that object to their mouth. They're being able to bring that preloaded spoon to the mouth. If I'm feeding baby and then baby's not making this feeding milestone, And it's important for babies to be able to do that because when baby's gag reflex is at the very tip of the tongue, and as baby feeds themselves, they'll move that gag reflex slowly but surely back. Just like our gag reflex is not at the tip of our tongue because we've fed ourselves for years. And so we know that we can move that gag reflex back in order to protect our airway. So it's really important for baby's gag reflex to move back so that that gag will actually be present and really push out any food in the event of choking. If the gag reflex stays at the very tip, then the baby's going to always do what's called a tongue thrust and not really swallow the food and not learn how to be able to protect their airway. So a baby-led spoon is important to be able to help achieve that preloaded spoon to their mouth milestone. And then babies are also supposed to independently finger feed at this age. So they want to get pieces of foods and bring that piece of food to their mouth. So when we are cutting foods for babies at this age, I see a lot of well-meaning educators saying, cut food small for babies, but actually baby's airway is about the diameter of a straw. So if we cut really small pieces of food, I see lots of well-meaning professionals saying, cut foods the size of a pea, and that's actually the exact size. If you think about a baby's airway being a straw size, if we cut foods the size of a pea, boop, it's going to include that. So we want to cut foods the length and thickness of an adult pinky finger. And why that's important is remember how we were talking about that palmar grasp earlier? If we cut foods the length and thickness of an adult pinky finger and I lay that piece of food down, the baby's going to grab it with that palmar grasp and bring that piece of food to their mouth. Families and caregivers usually struggle with the size of the food, so I actually designed a food cutter specifically for that, that parents can cut foods and it ends up being the length and thickness of an adult pinky finger with some nice ridges on the edges, so it makes it easier for babies to pick that up. So you can do bananas, avocado, roasted chicken. You can introduce allergenic foods like tofu, any soft, cooked sweet potato, cooked carrot, to be able to make those foods to be that stick shape so that babies can be able to grab that piece of food, independently put it onto their gum line and be able to start working on that munch chew, which is really important. So it all kind of builds together, the grasp and then bringing things to the mouth, cutting the foods the right shape for babies to decrease choking risk, but also help engage them into the stages for feeding and swallowing development to really help them kind of get ready for the next stage. So we are going to move on to showing you, hopefully you can see this, a 6-month-old kind of doing some of these things in action. I because of the time constraint, I just did cup drinking for this so you guys can see this, but hopefully you'll be able to see this. So basically, could you see that video?
Yep, that will look, yeah, I saw it
Okay,
and adorable, by the way.
great.
Little gnawing little baby.
I know, so cute. So it just allows it. So we saw that lane of baby coming in. I'm just holding it. You can see a little bit of breast milk on my hand. Baby's just being able to drink and using that lip closure and being able to hold on to that cup and leaning forward and getting a little bit of something to drink. So it's really important for us to kind of practice some of those exercises for baby and really help them facilitate those developmental milestones, especially coming into that lip closure. So baby had that munch chew and eventually baby's getting a little bit more. They're going from, kind of yum, yum, yum to being able to put their lips on there and be able to facilitate that. At 9 months of age, now we're moving down to before baby at 6 months, I'm preloading the spoon, baby's bringing that spoon to their mouth. At 9 months of age, we're looking for baby to grab a hold of that spoon and start dipping. So this is that up and down motion of dipping, which will eventually help with the up and down motion of piercing with the fork, which will come in a couple months later. So at 9 months of age, we're wanting babies to be able to start to do that dip and being able to dip that spoon and bring it to their mouth effectively. So that's a really important skill. We're also wanting babies to independently finger feed themselves with a new grasp. The first grasp was that palmar grasp, right? Using that whole hand to be able to grab foods. Now we're looking for a pincer grasp to be able to go from this to this. So babies' fine motor movements are starting to get more and more precise and allowing babies to be able to feed themselves. But again, we don't want those small pea-sized shaped foods. We want foods that are a little bit bigger in shape and still have some texture. So here's the other food cutter that I designed it, and it's a food cutter that you can press down, and it has 4 pieces of cubed foods that babies are going to be able to pick up with their fingers. It has those ridges to be able to help with that grip and being able to put that into their mouth. So we can fill up a bowl with those cube-sized foods. Baby's going to be able to use that pincer grasp and be able to work on that skill and also be able to bring that to their mouth. Of course, we can still have strip size pieces of foods in there too to kind of make that easier. So the palmar grasp and the pincer grasp is used all the way in infant feeding all the way up to 3 years of age. So we're still wanting these shapes, so you can use these shapes from 6 months all the way to 3 years, because we're still working on that palmar grasp and we're working on that pincer grasp, because those are the same movements that we need to be able to use a fork, to be able to use a knife. Those are the same types of grasp. So we want, again, this is all developmental. They all build upon each other to make it a little bit easier for babies to be independent. And then we're also going to start introducing a straw cup at this time. So why we introduce a straw cup after an open cup is because of muscle development. So the first muscle development is lip closure, and the next muscle development is more precise, because again, just like we're going with the more open hand to a more precise pincer grasp, we're doing the same thing with the mouth. Open with the mouth with lip closure, and then more precise called lip rounding. So when we're drinking from a straw cup, lip rounding. When we're drinking from an open cup, lip closure. So now we're going to start to introduce a straw cup. We want to choose a straw cup that has a very short straw. We want to choose a straw cup that does not have a valve, because having valves, you can't clean them, and it's the #1 cause of mold allergies in children. And we don't want a weighted straw cup, because again, you can't clean that on the inside. And what a weighted straw cup does is it holds the liquid down and primes the straw. And what happens with that is that the child does not learn the skill of straw drinking. And as a feeding therapist, what I want to happen with straw drinking is I want babies to, one, be able to learn how to control their respiration. That is being able to suck up air and be able to hold it. So everybody pretend that you're drinking from a straw. Feel that tension in your throat, that you're holding that air. Babies need to learn to be able to hold that air and suck. And if we use weighted straws that prime the straw all the way to the top, then they're only holding the air with a very, very small sip. And that is not letting them learn how to protect their airway to have multiple textures. So if you've got a kiddo that just can't handle textures that is in the toddler years, like pizza or a sandwich or a salad, they can't do that because they can't manage the respiration. So I always go back to straw drinking. You want to be able to have a short straw, no valve, no weighted straw, because then the child has to learn to hold their breath to be able to bring the liquid up and be able to be successful with that. So this is the shortest straw on the market as compared to other baby straws that are this long. They have to hold their breath for a really long time, which is why they end up choking. So if you have a short straw, it makes it really easy for babies to be successful with this. And then I have sensory bumps here on the very tip of the straw to help babies. Let's see if I can bring that a little closer. Nope. Still doesn't go in. Help babies keep their lips at the tip of the straw, because we want babies to keep their lips here instead of putting their whole mouth over it. If they put their whole mouth over a straw, then that means they're suckling like this, like they do with this sippy cup. We want babies to engage those lip muscles. Remember, we're working on precise movements to be able to keep the lips here. So if you use this straw cup, the sensory bumps are for babies to feel where they're supposed to place their lips, but it's also a visual cue for us as caregivers. If you don't see those sensory bumps, because their lips are being covered by the child, then they're not breathing correctly, they're not holding the respiration correctly, their tongue is not in the right place for swallowing, and their lips are not in the right place for swallowing. So that is the training straw side. And then once your child is consistently keeping their lips at the tip of the straw, then you can flip the straw over to the advanced side where there's no sensory bumps, and now the straw is straight up. The straw is curved on the training straw side because, again, remember, we want to keep that lips and head down to protect the airway to be able to help facilitate that. And then once the child is perfected with this side of the straw, then you can go to any straw cup. And because they've learned that skill of being able to hold their breath, be able to hold that respiration, and be able to facilitate that lip rounding, and they can move on to whatever straw. They can go to even longer straws like this and be successful. It's a disadvantage for kids when they start on such a long straw or they start on a weighted straw cup and they don't really learn how to protect their airway. And then they go to take a drink out of like your Starbucks straw cup or your Stanley cup, and then they cough and sputter, and then they don't want to drink from a straw cup again. And that is a very big detriment to their oral development because straw drinking is a milestone. We're going to introduce straw drinking at 9 months of age, but the milestone is that the child should be independent and perfect straw drinking by baby's first year. So we really want the babies to be able to practice that because, again, that's the only way that they're really learning to be able to hold that breath and kind of move on with their breath support. So those are 9-month-old milestones. Now we're at baby's first birthday. So now we've looked with the spoon, we've perfected, like they've perfected a preloaded spoon, they perfected dipping. Now we're expecting babies to start scooping and bringing that spoon to their mouth. So when we're working on scooping, we're going to go from the infant spoon to a little bit larger excuse me, of a spoon. And so that can manage a little bit more food. We want a small bowled spoon for babies at first because the tongue cups around a utensil in infancy. And so we want these spoons to be really small. I see a lot of spoons out on the market that are that are huge, like this big. And then you'll see the baby flip the spoon over and lick like this because their tongue can't cup around the spoon. And so babies aren't really engaging their oral skills. But at the first birthday, we can go to a bigger spoon bowl because we're actually working on scooping. So that is really exciting. And then we're introducing a fork. So it really frustrates me when I see other feeding companies putting a fork in babies' gear. And I'll get calls in my private practice of parents saying, I think my baby needs feeding therapy because my 6-month-old can't use a fork. And parents feel like they're not being successful or their child is, struggling with feeding. And that's not the case. Fork milestones don't come into play until baby's first birthday. And that's when we're introducing a fork. We're not expecting piercing skills till 15 months of age. So these parents that are feeling like they're failing at 6 months, that's why there's no forks in the baby products that I designed. This is a toddler fork for toddlers. And it's rounded too, because we want to stab our face with the forks that we give our children, because if it hurts us, it's too sharp for babies. We don't give babies sharp objects. The school for the blind that I contract with, the statistics there are 80% of the babies that are blind in one eye are blind in one eye because a caregiver gave them a fork. So I did not want to have any forks in my baby gear because one, it's not developmentally appropriate, and two, we don't give babies sharp objects. But even the forks for toddlers, we want it to, the milestone is that they're going to start piercing with a fork, but we don't expect perfection, and we certainly don't want to give them sharp forks, right? So we want them to be able to pierce like some tofu or watermelon and be successful with that. Pierce scrambled eggs and be able to start to learn that skill of them piercing up and down, but we absolutely do not want to give them sharp objects. So this will pierce pretty much any food, but it's rounded at the edges, and you want to look for that to make sure that we're giving a fork that's safe for baby. And then at this 12-month mark, there's still finger feeding. So there's still a milestone that they're able to finger feed. We're engaging with utensils, spoons and forks, and we're wanting babies to try that. But you'll see them start to use a fork or use a spoon like at the beginning of the meal, and towards the end of the meal, they're just grabbing the food and putting it in their mouth. And that's completely normal. Yes, it's going to be a little bit of mess, but that's completely normal because the milestone is that they should be able to finger feed, but they also should be able to start using utensils, maybe not in the best way, but actually using them for a little bit of the time. So we always want to offer a spoon and a fork at mealtime. And then the next milestone is that a baby should be able to drink from an open cup with spillage. So at the 6-month mark, we're holding the cup for baby and baby's leaning forward. At the 12-month mark, we're expecting babies to hold on to it and bring it to the mouth. And you might be wondering why there's no handles on these cups. And the reason why is because handles make it harder. It seems like it's going to be easier, but handles make it harder for children. So if I had my cup of coffee here and I have one handle, but if I had a second handle, I'd be holding it here. And if you have a coffee mug at home, no one's watching you, you try this too. Visualize you holding two hands. It is so hard to bring that to my mouth. And I'm an expert drinker, but if we're able to hold onto an object like this and bring it to the mouth, it's very easy. Babies can use their elbows, if you will, let me move my sweater up, elbows to be able to stabilize, to be able to bring that up. When their hands are out, it's very difficult. It's more challenging for babies. So we don't want to use cups that have handles on them. We want it to be easier for them to be able to bring it to their mouth and be able to be successful. So 6 months of age, we're holding the cup. 12 months of age, babies are actually bringing that cup to their mouth with some spillage. So you might be wondering what to put in the cup. So at 6 months, we're going to be doing breast milk or formula or purees and smoothies. At the 9-month mark, we're going to do breast milk or formula, purees and smoothies, and then we can start offering water. And the reason why we don't offer water early is because it can cause kidney dysfunction in children, and 4% of children can pass away from an overconsumption of water. With breast milk and formula, it has all the water needs that children need. Water is a thin liquid and it goes down the throat very, very fast, and it can be very damaging to the lungs for that liquid to go down. So we will introduce that at 9 months of age. So baby has had 3 months of practice drinking from a cup in order to prepare them for water. Another reason why we start to introduce water at the 9-month mark is because around 9 months of age, if I'm holding this cup, that baby is wanting to hold on to that cup too. And then of course we can have some spillage. So water is a really nice liquid to be able to introduce when baby's wanting to hold the cup and get ready for that 12-month old milestone of them independently having that cup. And then at the 12-month mark, we can introduce cow milk or plant-based milk like almond milks, etc. But that's not nutritionally recommended until that first birthday. So let's see this in action. Let's see a 12-month-old rocking out that cup milestone of bringing the liquid to the mouth successfully and independently, albeit with a little bit of spillage. And there we go. So it's a great way for babies to be able to have the success, and once we give them more opportunities to be able to try that. Okay, so now we're at 24 months. So at 24 months of age, the next cup milestone is that they're able to drink from an open cup with no spillage. I have 5-year-olds on my caseload that, unfortunately weren't introduced to an open cup till later that are still spilling, but we're really working on balance and we're working on that fine motor skill. So and we're working on that lip closure. A lot of spills happen because the lip closure isn't really developed. So we want to really practice with that. And then at the 24-month mark, we're going to introduce a training knife too. So this is one training knife I designed. So you can see it can show you how dry my skin is, but it doesn't cut to hurt children, which is why I designed it that way, but it also can cut a raw apple. So it's a great opportunity for, using soft foods like bananas and being able to teach toddlers to be able to cut with the foods. The developmental milestone is that they're going to use a training knife for spreading. So cream cheese, peanut butter, jelly, etc. They're spreading. So they're using this wrist rotation, and then also to be able to learn how to cut. So I like to do soft foods. I'm not giving them like raw carrots to cut, but soft foods to be able to practice that movement as well. And that's going to help with their scribbling and drawing and coloring and writing goals as well, because we're really working on that wrist rotation. And then, of course, we're still letting them at this age finger feed soft foods, which is really important to know that, again, that goes all the way to 3 years of age. So now let's talk a little bit about the differences between open cup and straw cup and sippy cups. So open cup promotes independence, but sippy cups promote independence too. So babies can be very independent with the sippy cup. Open cup, there's a potential for mess. With sippy cups, it prevents mess. With an open cup, it promotes a mature swallow pattern. So remember that tongue coming up to the roof of the mouth. A sippy cup promotes an immature sucking pattern, this anterior posterior movement, because that spout blocks the tongue elevation. So when that spout is on in the mouth for them to drink, it's holding the tongue down. And it doesn't matter if you use a hard spout or a soft spout, it's holding that tongue down so they cannot drink safely and effectively. They're suckling and they're pulling the liquid instead of lifting the tongue up to get that liquid. An open cup and a straw cup promote dental facial development. So a lot of kids who are on sippy cups, you see that their jaw does not grow as much. It doesn't come out. So they're not as attractive because that jaw formulation is not as good and their lips are not protrude out as much. So an open cup and a straw cup promote that dental facial development. There's so many of my colleagues in pediatric dentistry and pediatric airway that is really focusing on this, that the jaws are just becoming so retracted. There's so many great books on this subject. If you're interested in that, I can give you that information, but some of the books are like Airway for Life and Jaws are like a really good books about dental and facial development. Promotes nose breathing. So if we're drinking from an open cup, they're breathing through their nose, not through the mouth. If they're drinking from a sippy cup, they're sucking and breathing through their mouth. So it definitely can impact breathing issues and dental facial difficulties. An open cup and a straw cup promote mature eating and drinking skills because we're learning how to protect our airway by bringing that tongue up to the roof of the mouth. And with the sippy cup, it may complicate the acquisition of those skills and the safety and the impact of that. And then every 4 hours in the United States, a child under 3 years of age is sent to the hospital because of damage from a sippy cup. They're usually lacerations to the mouth because a child is a toddler or a baby and they're learning how to be able to walk, and so they might fall and use the product, or they hurt themselves while drinking from a sippy cup in a vehicle. So those are some different safety implications of sippy cups and why we want to promote straw cups and open cups, and also not only help with safety issues, but also the dental and speech issues that can be complicated as well. And then now we're here at 36 months. And so at 36 months, this is where we're going to stop, and then we'll open up to questions here in a second. They're able to use all utensils independently. They're able to finger feed all soft foods. They're able to bite through various thicknesses. So they should be able to kind of bite through pizza and being able to go through all those textures of like the cheese and the pepperoni and the sauce and the crust. They're done with the teething process, hopefully by now. Usually teething is from 4 months of age to about 36 months, and they're able to drink again from an open cup with no spillage. So let me show you a 3-year-old that was really showing off in this video, but trying to drink consistently and drink and guzzle a lot and show that she wasn't losing any of her liquids through her mouth. And of course, breathing through her nose, keeping that good lip closure, and then gasping for breath afterwards because she drank so much. So that is really what we're hoping to be successful with, is having all these developmental milestones from that 3 month mark all the way to 3 years, and being able to really build upon each other to help facilitate really good oral development. And as a speech pathologist and feeding therapist, I'm constantly assessing and treating the whole child, and possibly looking for feeding and swallowing delays or disorders, and look for anything that impacts that function. And so if we maintain this development, then not only are we going to have good feeding outcomes, we're going to have good speech outcomes, good language outcomes, good social skills outcomes, because feeding milestones precede speech milestones. All the things that we do with our mouth and jaw for feeding are all the things that we do for speech and language development too. So that is really important to kind of think about when we are looking at these feeding and swallowing skills. So my hope from today's talk was that it piques your interest in feeding and swallowing milestones, and that you might dive in to give the children in your life the opportunities to try these skills. And if you're like, oh my gosh, my child is not doing this, that's okay. You can practice and make it fun. You can do it at mealtime, you could do it at snack time, you could do it outside at the park, you could do it in the bathtub with cup drinking, and just offering your child opportunities will help them be able to get that. And if you're interested in more feeding topics, you can join my feeding webinar. This is another webinar I'm doing tomorrow, actually, for parents. If you're a parent and you're interested, you can scan this. And I'd love to be able to open the lines here for any Q&A and any questions that you guys might have.
Thank you so much, Dawn.
Oh, you're so welcome.
Awesome. Thank you so much for all that information and everything like that. We'll go ahead and take some questions now, so it's not too late to get your questions in. So we did have a participant that asked where they could purchase these feeding utensils that you were referencing today.
Oh, yeah, they can go to easypeasyfun.com. That's EZPZFUN.com for all these, but they're also in Nordstrom's, Creighton Kids. Some of them are on Amazon, some are in Target. A variety of different places.
Okay, great. Thank you so much for that. And when we had somebody ask, when should parents seek help from professionals regarding their child's feeding and oral development? Is there a time that you should be looking out for something specifically, or maybe is there something that you see typically that usually calls out at an earlier age?
Yeah, if you notice that, especially with these milestones, if you notice that you're like, oh, my child is a little bit delayed, maybe it's 3 months delayed, or maybe it's 6 months delayed. Every state in the United States, and if those of you who are tuning in from Canada, you have something very similar as well, gives free and appropriate services in feeding from birth to 3 years of age. You just usually end up being on a waiting list. So every state has that skill. So I always tell families early intervention is key. And
Mhm.
if you feel like your baby is a little bit delayed or your toddler is a little bit delayed, you have up to their third birthday to be able to get free services from your state. And I always say, if you feel like they're just a little bit delayed, get in early, because there's usually a wait list, because there's thousands of families in your state that are also looking for those same services. After your child is 3, then it ends up going to the school district. And unfortunately, the school district is not able to offer a lot of sessions. So usually with the birth to 3 community, I get an hour with the child, and the school district, I might get 15 minutes once a week. So it's
That
very,
intervention
very
is very,
different.
very, yeah,
Yeah,
gotcha.
and
Interesting.
sometimes with the birth to 3, I can get that hour 2 or 3 times a week. So that child may be getting 3 hours of therapy as compared to 15 minutes in the schools.
Wonderful, wonderful. Thank you for that.
Yeah.
We had a question that's come in. It says, with baby-led weaning, baby 9.5 months will put soft piece of mango, etc., into her mouth for a few seconds and spit it out. I find she doesn't often swallow foods. Is that normal?
Yes. Yes and no. So remember we were talking about that munching? So what it might be for mango is a perfect example. Mango is a slippery food. So you could either cut it with a crinkle cutter to give that a little bit more grip
Mm.
to be able to facilitate that. Of course,
Yeah,
you
could
could
you show
use,
that again? Yeah, I was gonna say, I
yeah,
know
so
there were some
this,
people that are saying they had a hard time kind of seeing just because of the transfer from, um, from the PowerPoint to that, but obviously
gotcha.
this will be recorded and sent out for everybody on today.
Yeah, so this is the food cutters that I designed, but you can
Gotcha.
also use a crinkle cutter, which is just a kitchen tool. You just want to basically make some kind of wave motion onto those slippery foods like mango, avocado, banana, etc., to make that easy for your child to grip, but also make it easy for that tongue to find. The more texture that the food has in the mouth, the easier your tongue is able to find it. I just like using the example of like when you go to the dentist and they put in that tube to suck out your saliva because your tongue can't elevate when you're laying back. But your tongue always finds it, right? All of a sudden, your tongue's in there because your tongue is supposed to protect your airway. So we want that tongue lateralization. But with slippery foods, if your tongue can't find the food, then the only two options is that to let that slippery piece of food go down the throat or for you to spit it out. So
Mhm.
it looks like she just needs a little bit more time to be able to find that so that she can work on that munch chew. You can also roll it in some oats or some any type like a crushed cereal to give it a little
Yeah.
bit more texture. But offering that would be good. If she's doing that with all foods, then I definitely would seek some help because at that 9 month mark, they should be able to chew and swallow effectively. And then you can get on one of those wait lists to get some free services for your baby. And sometimes, don't be afraid. Sometimes it could be 2 sessions. Most of the kids that I work with, it's only 2 sessions. And we just kind of get baby back on track. Parents know what to be able to work on. It's not like you're like, oh my gosh, my child's in therapy forever. It's usually like a couple of sessions and you can knock it out really easily.
Great, thank you for that. We did get just one. It says, my 23-month-old will absolutely not eat lunch and dinner on her own at home. She will at daycare with some pushing. She has great control with a fork and will pick things up, but also almost never puts it in her mouth. I'm almost always feeding her myself. Can I encourage her to feed herself more consistently?
Yeah, one of the strategies that I end up doing with kiddos who are struggling with wanting to be able to eat is let them feed you. And the reason
Mm,
why there's this thing called mirror neurons. And basically it's kind of like if you are feeding, right? We tend to open up our mouth. We tend to do what
yeah.
we want the other person to do, right? So we're like, right? And
Yeah.
so what happens if she feeds you, then she's going to be opening up her mouth. And what that does is that the brain will tell her that that food is safe and that food
Mm,
is good because she's as she sees, let's say let's use mangoes, keep going with that. She sees the mango going into your mouth. Her brain is saying mango is safe. I can put mango in my mouth. And she's even opening up her mouth as she does that. So let her feed you. That can be really fun for the child and really engage that. And then it can also be something, if you end up having to feed her, then let's say it's mango too. Put the mango here. Have her lean forward for the mango.
mm,
Because if you put it into her mouth, remember, I'd love for someone to feed me. I could just max and relax and not work on any skills whatsoever. But we want her to engage and try to bite through. And then you could say things like, instead of saying, oh, good job, say, I like the way you used your teeth to bite that piece of food. I liked how you chomped that food. Ooh, you're a good chewer. Look how your tongue licked that piece of mango that was on your lip. Let her know the skills that we are looking for because sometimes kids just don't know what the expectations are. And
mm,
maybe she fed herself really good a couple months ago, but now that oral cavity is totally different. Our
mhm.
kids' mouths, that's why I said use a tongue depressor and look in there every single mouth because it's constantly changing. We are dealing with a system, a sensory system, and a motor system that is changing every single month. Now they have a new tooth. Now they have more saliva. Now their jaw's getting bigger. Now their tongue's getting bigger. There's so much going on that it's not really that the kids are picky. They just don't know how to use those muscles
Yeah,
correctly.
very interesting.
Or all of a sudden they're bigger and they're like, I was able to use my tongue and tell my tongue what to do, but now it's bigger and it's taken me a little bit more practice to be able to do that. But you got this, Mama.
Yeah, we'll take one last question.
Okay.
Um, Somebody asked, a 3-year-old doesn't like using utensils, extremely picky, eats well at daycare, but when she's at home, she'll only eat noodles, absolutely no vegetables. What can we do to support other?
Yeah, I would ask the daycare some of the strategies that they're using. Maybe it is that they have peers to be able to look at. So I always encourage parents, like whatever you want your child to eat, one of you need to be eating as well. So if you want your child to eat asparagus, but there's no asparagus on your plate, they're not going to eat it. So we have to be able to kind of encourage whatever it is that we want to be able to eat. And it's very normal for a child to go through a picky eating phase. That is normal development. You and I went through it. All of you went through picky eating. But picky eating is supposed to last weeks, not months or years. So if this has been something that you've been dealing with for a couple of months, I would seek out a feeding therapist because it's going to it's unfortunately will get worse because as she just wants to eat the same types of foods, let's say noodles, then eventually we'll lose noodles. So I always tell families get some services in early so that we can kind of expand those food preferences and kind of figure out why that is. I've had 3-year-olds that have had an undiagnosed tongue tie the whole entire time. But now at 3, they have all their teeth, and it's really difficult for that tongue to be able to manipulate. So having a medical professional in on the case to kind of look at some of those things can be really a game changer for you and your family. If you feel like you are dreading meals every single time, like if you're dreading dinner, get a feeding therapist involved to be able to help your family.
Awesome. Thank you so much for answering all those questions with that great feedback. That is our time for today. So thank you so much, Dawn, for joining us today, giving us all those resources and guidance. I learned a few things I wish I would have known 7 years ago today. So definitely make sure that you guys take a look at this, share Miss Dawn's tips and tricks with everyone because especially as a first time mom, it's just stuff that you don't know. So I
Right.
learned a lot today. Thank you so much, Dawn.
Yeah. Thank you so
Um,
much for having me.
yes, we'd like to remind all participants that there will be a recording sent out today, as well as a survey that'll be popping up when the talk ends. So if you please just take a quick second to fill that out, we'd appreciate it. Thank you everyone for dealing with our technical difficulties today and for joining us late and staying and asking great questions. And we'll see you next month, November 20th, for our next talk. Thanks so much, guys. Bye, Dawn. Thank you again.
Bye. You're welcome. Bye bye, everyone.